Ibrahim. Dr. Nihad is a professor of clinical oncology, Department of Breast Medical Oncology, MD Anderson Cancer Center, USA. His topic is a very interesting topic dealing with anti-HER2 inhibition in neoadjuvant and metastatic setting in breast cancer.
In 20
Dr.
minutes.
Nihad, please.
Thank you for this introduction. Again, want to thank the chairman of this session as well, or chairperson, as well as the organizers. And without ado delay, because it's a very large topic, let me move on. It was going to be two parts: dual inhibition of HER2 in neoadjuvant breast cancer, and the second part is the dual inhibition of HER2 in the metastatic breast cancer. So, because I know that the time limit is very significant, I really worked very hard to compile most of the neoadjuvant data in one slide. And I divided the studies that were done with dual inhibition in neoadjuvant therapy into two groups. One where anthracycline was used in addition to the taxanes, and the other one were two studies where they were anthracycline based. The non-anthracycline based, as you are all aware of at least the names and some of the results that we know of, were the Neo-Alto CLGB 4601 and Neo-Sphere. And all of these were taxane based. The first two used trastuzumab and or lapatinib or the combination, and the Neo-Sphere uses, in addition to taxane, trastuzumab, pertuzumab, or the combination. And I want to draw your attention here that the pathologic complete remission in these studies by dual inhibition was significantly better than the mono inhibition, which is trastuzumab or lapatinib in the Neo-Alto and the Neo-Sphere trials. And this is basically sum up these trials and the results of which. Mind you that the toxic profile of these studies were very well accepted, and there were no significant increase in the cardiotoxicities. In the anthracycline based, there were also arms where there's only dual inhibition or that is associated with the anthracycline or not with the anthracycline. And we noticed that with the use of anthracycline and the dual inhibition, the pathologic remission rate in the two studies cited here, B41 and Trifina, were 71 and 62%. And in the B41, the difference was statistically significant. In the Trifina, it was not calculated. However, in the Trifina, there was also a third arm that is based on TCH plus pertuzumab and showed a pathologic remission rate of 66%. Now, when you look at the panoramic view of all these studies, you see that probably, and I would say probably because we don't have statistical validation here, probably that TCH plus pertuzumab as a neoadjuvant is the front runner in the neoadjuvant therapy with HER2 positive tumors. In addition, in the CLGB trial, Dr. Lisa Carey tried to subclassify the responses of the patients to see, since this study was not statistically significant, tried to see if there is any subgroup that benefited more from the chemotherapy versus not, and it found out that the HER2 enriched probably benefit more than the other subgroups, basically basal-like, luminal AB, or normal-like. Future studies that are being awaited is the B52 trial, which is looking at TCH with pertuzumab and in HER2 positive with estrogen deprivation, and GPAR-62 trial looking at paclitaxel, liposomal doxorubicin, trastuzumab, and lapatinib with or without carboplatin. So try to make up a hybrid of all the positive lessons that we get, and you saw on the summary slide. where do we go from here? I did not want to call it summary. I did not want to call it anything. I thought reflection is the right description of what I am thinking of myself when looking through all these trials. I think that dual targeting in combination with chemotherapy, consistently achieving high pathologic remission rate. Future neoadjuvant trials should focus on improving pathologic remission rate in the HER2 ER positive subsets, and predictive biomarkers cannot be emphasized more. You have in my colleagues, Dr. Rubin and Dr. Alvarez, that this is the way to go to try to find patient subsets that may benefit from one approach rather than the other. ALTO and Affinity are trials which are in the adjuvant setting are highly awaited, and the future development should focus on patients with partial responses, pathologic partial responses, or high residual disease patients incorporating immunotherapy. And you heard Dr. Rubin how important the microenvironment and the immune environment is important in future developments. Dual HER2 inhibition in metastatic breast cancer. Undoubtedly, trastuzumab has changed the natural history of HER2 positive tumors, improving the overall survival. And this is something we cannot ignore at all. However, where do we go from here? There is still a lot of patients who recur despite their response to Herceptin-based therapy. And we need to figure out why they were not cured in the first place. And probably this is because of development of, again, don't ask me what's the definition of primary and secondary resistance, but possible mechanisms of resistance known so far would include crosstalk with other ARB members or IGF, presence of P95 truncated HER2, P10 deficiency, increased PI3K, AKT pathways, and RAC1, which is a RAS-like small GTPase, which prevent the HER2 endocytosis. However, the clinical and/or the complete loss of dependence on HER2 signaling, therefore, is not very well known. Just we know that there are potential mechanisms of resistance. The way how to overcome it remain to be studied. And novel HER2 target agents may improve survival benefits in the patients with metastatic breast cancer. Just a general view of all HER2 receptors and how they interact together is shown here. And we know now at the present time that probably the interaction between HER2 and HER3 is the most important or clinically significant in signaling in cancer cells. However, we have only at the present time 3 drugs that we are using in the clinic that may help control the disease with this problem, including trastuzumab, lapatinib, TDM1. On purpose, I'm omitting TDM1 discussion here, and I want to thank Dr. Hamada because he rescued me in this sense, and thank him also for giving a very comprehensive review of trastuzumab and lapatinib literature. There are multiple trials here that we look at, including the drugs pertuzumab, TDM1, everolimus, and afinitab. And let me quickly review some of the data here, including the study with EGF-1 04900, and you heard about it earlier today, that lapatinib versus lapatinib trastuzumab showed significant improvement in overall survival in favor of the dual inhibition. I think one of the importance of this study is it was an eye-opener that dual inhibition works, and we really started looking at it with a great emphasis, particularly that it improves significantly the overall survival when you use the dual inhibition instead of the single inhibition. Pertuzumab and trastuzumab, again, they have been used in combination based on preclinical data of that they will work synergistically. And there are multiple studies. So far only we have data on Cleopatra. The others are still ongoing. And the Cleopatra data, as you all know, very famous trial. They quickly became very famous, and the drug TDM1 has been, Perjeta or pertuzumab has been approved in the United States based on this data. Looking at docetaxel and trastuzumab and the placebo versus docetaxel, trastuzumab and pertuzumab, patients with metastatic breast cancer, frontline. The primary endpoint is assessment of the progression-free survival, and secondary endpoints is the overall survival as well as objective responses and safety. Taking it one at a time, the response rate was significantly higher in the triplet versus the doublet, and that was statistically significant. Looking at the progression-free survival, also it was statistically significant in favor of the pertuzumab arm, with a difference of 6.1 months, which is really a very, very significant number. Overall survival also at 3 years was statistically significant, 66% versus 50% in the placebo arm, and the median overall survival in the placebo arm were 37.6 and not reached in the pertuzumab arm. Therefore, Cleopatra study is showing that there is a significant increase in the progression-free survival and probably of survival. Survival data not mature yet, however, and the final analysis is expected. It was expected later 2013 or probably in 14. Combination of pertuzumab and trastuzumab and chemotherapy did not increase the rate of symptomatic or asymptomatic heart problems, and the grade 3-4 adverse events included increase in the neutropenic fever, diarrhea, rash, and dry skin. Multiple other trials besides Cleopatra are still awaiting results. Most importantly is the Marianne trial. There are multiple other novel drugs that are being tried in this setting, and the list is very long, and I really focused on everolimus because it is an mTOR inhibitor, and mTOR appears to be a central player in the resistance to HER2 based therapies. And not only that, there was only intermediate steps there that can be interrupted, which I put here in these boxes, which are focus of a lot of research, and most of the drugs approach these facets in a very thorough way. Most importantly, at this point in time, is the Bolero 3, which showed improvement in progression-free survival when everolimus was added to trastuzumab and weekly vinorelbine. Again, the conclusions is that there are multiple drugs that may address HER2-positive tumors, including trastuzumab, pertuzumab, TDM1 that I did not discuss, in addition to lapetinib. Preferred first-line regimen includes the dual inhibition with pertuzumab and trastuzumab, in addition to docetaxel. There are also other HER2 inhibition agents that continue to play a role in the first line, particularly where pertuzumab is not available. I tried also to put it in a figure form where multiple agents may be used or investigated either in phase 1 or phase 2 trials, try to interrupt the HER2 down signaling pathways. So preferred regimens, again, is the taxane plus pertuzumab and trastuzumab. Again, if it is not available, the pertuzumab is not available, you can use the trastuzumab with paclitaxel and carboplatin. Most of us had a lot of experience with this combination. Docetaxel and trastuzumab, vinorelbine or capecitabine with trastuzumab also are very important. And the NCCN paradigm includes after failure of pertuzumab, trastuzumab, and docetaxel, use of TDM1. However, don't forget the other combinations such as trastuzumab and lapatinib, or most importantly, clinical trials. With this, I will end. I see very early, which I'm happy with that because it may give you more time for questions.
Thank you, Dr. Nihad, for your elegant, informative, updated presentation. Now the floor is open for one, maximum two, being late. Okay, would you please?
Thank you, Dr. Nihad, for an elegant presentation. My question about the addition of triple anti-HER2 therapy, like trastuzumab, pertuzumab, and lapatinib. Do you have any data about this?
No, we don't. But I would be very nervous doing a trial like this because of probable toxicity. Remember when lapatinib is added to trastuzumab and capecitabine trials, it resulted in a lot of side effects also. I think the tolerability might be an issue there, but there is no trials designed or, to my knowledge, planned with the triple inhibition.
Okay, no more questions? Okay, thanks a lot, Dr. Nihad.
Now I have the pleasure to present